The second part of the manual handling training presentation will talk you through the fundamental steps that you need to follow for 5 different transfer techniques. These are transferring an object from the floor, pushing and pulling, sit to stand, lying to sit, and rolling. When transferring an object from the floor, we need to make sure that we stand close to the object and then squat to the floor. For those staff members or therapists that cannot squat to the floor, this could be because they have a poor squat technique or they have a certain pathology in their knees or their ankles, which makes it difficult for them to squat. In that case, they can kneel down on one knee. Some staff members and therapists are unable to do both because of certain health conditions. If that is the case, then they need to discuss that condition with the facility management and make them aware that they are not suitable for tasks that involve picking up objects or boxes from the floor. Once you have taken a squat position close to the object, we need to hold the object with both our hands, bring the object close to our body or to our chest, and then stand up. It is really important that the object is held close to the body with both hands to prevent the object from falling or from us falling because we've held the object too far away from our body. As we all know, that affects the center of gravity and hence our balance. We can then place the object where required by stepping. The reason why I've put in stepping there is because if we're required to pick up the object from the floor and then turn around and place the object on a table, we need to make sure that we are not twisting at the back when turning. That turn needs to be done with our steps. So the important steps to remember for this particular transfer technique is no bending at the back. We squat or kneel to the floor instead. We do not twist at the back to place the object. We use our legs to step instead. Pushing and pulling techniques are used routinely by staff members as well as therapists when handling trolleys, chairs, and hoists. And so this is a technique that is used equally by laundry staff, by kitchen staff, as well as nursing staff. As much as possible, we try to minimize pulling. And as I have discussed in the previous training video, this is because pulling techniques are associated with a very high risk of extension injuries in the lower back, which can then lead to disc bulges and disc compressions, which can in turn lead to sciatica. Therefore, we minimize pulling as much as possible. We encourage staff to push forward or to turn around and then push rather than pulling trolleys, chairs, and hoists backwards and stepping back with them. When you are pushing or pulling, whether it is a trolley, chair, or hoist, we need to make sure that the handlebars are held between chest and hip height. Some chairs, such as fallout chairs, have adjustable handlebars. So if the handlebar is too high, you need to then adjust it so that it is placed between your chest and your hip prior to initiating a push. Before you push a fallout chair or a wheelchair or a trolley, we need to make sure, of course, that the brakes are off and that we initially get into a lunge position stance. This is because we want to generate momentum through our body weight and our front legs rather than creating the loading forces from our shoulders. So it is important that staff members take a lunge position at the beginning of the pushing technique and then push with their body weight to initiate the wheels rolling. Prior to initiating a sit to stand transfer with a client or a resident, we need to ensure that the client or the resident have placed both their arms on the arms of the chair. If the chair has no arms, then obviously this step is not applicable. Their feet also need to be flat on the floor and at least at a 90-degree knee bend. If you can push the knees at slightly more than a 90-degree knee bend, that's even better, but we need to be mindful of the fact that a lot of our aged care residents in particular have very severe arthritis and may not be able to achieve more than a 90-degree knee bend. We then ask the client to lean forward, bring their nose over their knees. If they're unable to do so themselves, we need to assist with leaning them forward. We then stand behind the client in a lunge position, which means that you have your front knee bending and you are leaning over it. We place one hand to support the client's shoulder and the other hand across to the opposite hip. This could be a one-person or a two-person transfer, but irrespective of how many people are doing the transfer, we need to give a 1, 2, 3 count. Now this count is given so that we can give adequate notice to the client that we are about to initiate a stand so that they are prepared for the stand. As you transfer the client from seat to stand, you need to go from a lunge to a stand. So essentially you're generating the loading force that is creating the seat to stand from your legs and your body rather than by pulling the client up into a stand through your arms. Now, there are a couple of very important points to note here. One is that we do not pull up on clients' pants or their pads to pull them into a stand position. And of course, as I have mentioned several times in the previous video as well, we do not hook the client to stand them. If a client or an aged care resident is unable to stand using the correct sit to stand technique I have just outlined here, then essentially we need to reassess their mobility and transfer and perhaps assess them for a hoist. To assist a resident or a client to achieve a lying to sit transfer, we need to verbally prompt the client to roll to one side. The side that they should roll to should be the side closest to the destination that they're trying to get to. For example, if they would like to get to the bathroom, which is on the right side of their bed, we need to then verbally prompt them to roll onto the right side. We then prompt the client or the resident to bring both their legs over the edge of the bed. We can lower the bed height so that their feet are on the ground or as close to the ground as possible. If verbally prompting the resident or the client is not working and they're not able to achieve the transfer without assistance, we need to then provide physical assistance for the roll as well as for bringing the legs over the edge of the bed. Once that part of the transfer has been achieved, we then prompt the client to place one hand in front of their body on the bed and push through that arm to propel themselves into a sitting position. We can further assist by raising the head of the bed if that makes it easier for them to propel themselves into a sitting position. If all of these techniques with raising the head of the bed and prompting them to push through one arm does not work, we then need to further assist the client or the resident by standing behind them, placing our hands on their shoulder, and then physically assisting them into a sitting position. We begin a rolling transfer with a resident or a client by first of all ensuring that the height of the bed is adjusted to the shorter staff member's hip height. Now this is a two-person transfer and it cannot be anything lesser than a two-person transfer at any time. We also need to make sure that the bed brakes are on. All of the bed brakes need to be on. If the bed has individual brakes on each wheel, we need to make sure that each of those bed brakes are on. We then cross the client's arms across their chest and bend the knee that is opposite to the direction of the roll. For example, if we wish to roll a resident to face the right side or onto their right side, we need to ensure that we are bending the left knee. When we bend that knee, we need to ensure that we do not slide their heel along the bed. Repetitive sliding day in and day out can lead to pressure sores which may get infected and can lead to infections. As this is a two-person transfer, one staff member places one hand on the client's hip and the other hand on the client's shoulder. They need to then adopt a squat or a lunge position on one side of the bed. This is the staff member that will push the client into a roll. The second staff member places their hands over the first staff member's hands. This staff member is the staff member that will pull the resident or assist the first staff member in rolling the resident onto their side. We then initiate the transfer with a 1, 2, 3 count to prepare the resident. The staff member that is initiating the roll through the lunge or the squat needs to ensure that the loading force they are generating is generated from their body and from their lunge and their squat and not their arms. We also need to ensure that we place our hands over the client's or the resident's shoulders and hips, and at no point are we pushing on the knee or pushing on the elbow. This is because pushing on the knee can lead to dislocations at the hips, and pushing on the elbow repetitively can lead to subluxations or dislocations at the shoulder.